I've got eminent speakers. Dr. Sudarshan Puthal is there. Dr.
Yes, sir.
Okay, Dr. Sudarshan Puthal is there. He is the professor and head of the Department of Pulmonary Medicine, SJMCH Puri, and Sri Jagannath Medical College and Hospital, and a renowned clinician. I know him. I've heard him in different platforms and in pulmonary medicines. He is our first speaker, and then the second speaker will be from Kolkata, Professor Dr. Sugata Dasgupta. We welcome you, sir. And he is the professor in Department of Critical Care Medicine, IPGMER, Kolkata, and he is also an eminent clinician. We have been practicing. I've been practicing since about 51 years now. And then now, when I see that the time that we were practicing and then present practice is a hell and heaven difference. And the problem that we face in different spheres is also much bigger. I don't want to take much time, but just to introduce, the real problem is not the technology, but it is the price tag attached to the technology, the price tag that is attached to the technology. The hospitals and doctors invest in expensive machines, and then the pressure to sell begins. And that is where the real game starts. The machine slowly begins to sit above the doctors. And that is what we have been seeing now. I wonder, how do we tell a patient that a robot is better than a doctor? How do we say that? How do we share that? Everyone is going for, the patients are also inclined to hear about the robotic surgery. The human skill, the judgment, and the years of experience are somehow secondary to a device. Set apart is many patients. Sad part of it is that many patients who can barely afford it are made to believe that robotic surgery is the only safe option and that the conventional surgery is outdated and inferior. They stretch their finances and borrow money and undergo procedure they never needed in their form ever. I'm not saying that against the technology or rejecting the technology, but rather the question that intent behind its use, the intent, the purpose behind the use. When the investment drives devices communication more than ethics, patients end up in carrying an emotional and financial burden. The guilt is heartbreaking and unfair. Pause for a moment and reflect. Are we empowering patients with knowledge or trapping them in the narratives built around recovery of the investment? Because when business starts leading the services, it is not progress, it's rather paradox. With this introduction, I would request Dr. Sudarshan Puthal to please go ahead with the topic, and then whatever, your time starts now, and then you can take around 30 minutes to complete your talk. Dr. Sudarshan Puthal, please. The time is yours.
Thank you, sir, for your kind introduction and also introduction to the topic. May I audible?
Yes, sir. Yes, sir.
Yes. Okay. Sir, good evening to everybody. Dr. Anirban kindly share my presentation so that I live in a better position, because Dr. Anirban, please.
Yes, sir.
Kindly share my presentation.
Yes, sir. Yes.
First of all, before going to discussion about my topic, it's a very interesting topic. Yes, nowadays, our moderator Sujit Sir told about that, very interesting. See, basically, first of all, I'm most thankful to the organizer giving me the opportunity, being the part of the platform, because I know this is very, very important, that too very Nowadays, in the era of, as sir is told, moderator sir, the era of artificial intelligence, so we need very much to need to know about the what is the difference between our clinical medicine versus investigation-based medicine. That's why I'm most thankful to the organizer giving me the opportunity. It's a very good topic. Let's have a discussion. Let's have thoughts of different speaker as well as myself, as well as from the audience side also. So let's coming to my topic. Anirban, please, next slide. What I going to discuss in the couple of time, my agenda look like this, that what we mean by clinical medicine and simultaneously what we mean by investigation medicine. What is the importance of both of them, whether it is a contradictory or a complementary. Say, next please, let's come to case-based approach. Let's come to the case. Say, 58 years old male come to outpatient department with a laboratory report and asked for advice. He had a history of vomiting. The treating physician advised some medication, but based on some Google search, patient done some investigation and come with investigation to the OPD. Patient is conscious because come to OPD by walking itself. All vital signs are normal. Sodium value, he came with these reports, sodium, potassium, and chloride. Sodium 110 milliequivalent, potassium 3 milliequivalent, chloride 8, all are in lower side. Question arises, what should be done? We have a three option. Because sodium is less, definitely some clinician plan to start 3% NaCl. And because potassium is low, again some clinician may plan to start KCl injection. And some part of time, it may have felt that in periphery setup, probably I may not treat the patient properly, so let's shift the patient to the higher center. Or in other way, initially let me start sodium followed by potassium. But basically, if you analyze the case, whatever the sodium value is 110, it is definitely less than the normal value. Potassium value also less than the normal value. Chloride value also less than the normal value. Of course, patient having some history of vomiting, but based on the Google search or internet available to everybody, based on the artificial intelligence, patient is a non-medical, so he done some investigation. Then only once he find that it is low, that's why he came to the physician. So what should be our role? See, whatever this report is so that, but all report are in lower limit. That's why Google search or internet shows that some medication should be started. But simultaneously, we need to understand what is the clinical background and what is the clinical aspect of this report. Patient sodium 110, patient should be, if value is correct, then probably patient may not able to walk and come to OPD. In this background, you see, a report is this. If we believe the medical report or the report, then probably we didn't need to treat the patient. But we need to interpret the report in clinical context. Next PPT, please. That's why my message, never believe a number blindly. Believe your eye, ear, hand, and brain. Never treat the report, treat the patient. What does it mean? It means that we need to interpret the report in based of clinical context. That means if patient having sodium 110, patient could not walk. Either report is wrong or some other error might be there. That should be keep in mind. Next, please. So, what I mean to say, the basic of our clinical context and clinical medicine is history. history composed of many things. Means complete age. We know our third year clinical classes. You might be observing that whenever we are taking the history, we need to take the chief complaint, present illness, past illness, medical history, family history, and so on and so. But this is the basic, because history will tell us many things. Based on history, then only we can treat the patient. That's why I'm telling you, we should treat the patient, not the report. We need to correlate the report with the clinical context. Next, please. Whenever we're taking the history, it is very important because, of course, this session is not a mandate to how to take the proper history, but some tips or tips I want to give the message to the August audience. Say, whenever we take the history should be presentable. Means what I mean, if patient is unconscious, of course, we cannot take the history from the patient. So we should take the history from the relative. And it should be approachable. Means what does mean? Whenever we are used to take the history from the patient should be approachable to the doctor. Because many of times what is observed, many of times the best of your patient or patient relative may not be express everything to the patient. That's why being a physician or a clinician or whatever may be a doctor, our position should be approachable to the patient so that patient or patient related being can express their feelings of proper history. And we should be receptible. That means not that whatever the patient is telling, we should not ignore it. Our approach should be receptible whatever the patient is telling. Because many of times it has been seen that in our OPD practice also, we feel many things, whatever the patient is telling, may not help us for the diagnosis. But dear friends, you might be observing that we are not giving the importance to the patient's history or patient's complaint. But that complaint may not be relevant for the diagnosis, but that complaint maybe have a definite clue for the diagnosis. Many of times, say for example, many of times, whenever we are asking the patient, what is your complaint? Patient is telling, so for example, patient is telling my headache is my complaint. But that is depends upon the patient's perception. Patient's perception is very much important. What does it mean? But when we examine the patient, we found there is a fever. Patient may not felt the fever, but patient felt a headache as a fever. That's why, what I mean to say, each and every parts of the history is important, and we should not ignore any complaint of the patient. That's why it should be receptible for us. Simultaneously, we should look for the past record of the patient. Next, please. So, whenever clinical medicine is concerned, we have a basic things, which is the foundation, history, examination, and clinical intuition. What I mean to say, based on present illness, chief complaint, and past illness, whatever the history is taken. Based on the history, followed by examination, we can narrow down the clinical differential diagnosis. This is very much important. That's why history followed by clinical examination, because history will give us, say, 4 to 5 differential diagnoses. Once we clinically examine the patient, our differential diagnosis is narrowed down. Because this narrowed clinical diagnosis, 2 to 3 clinical differential diagnoses help us to dictate or advise what investigation ideally should be chosen. That's why clinical medicine will help us inform of history, clinical examination, as well as clinical intuition. Yes, next please. This clinical medicine also have strength because it is a holistic approach. We can understand the patient's symptoms in relation to the disease. That's why it is a holistic understanding of the patient's perception in respect to the clinical finding. Many of times it has been seen that based on clinical history and clinical examination, we can order the ideal investigation. These are also cost effective and accessible to us. And it is also based on clinical medicine only, history and examination, we can choose the proper investigation. Our basic NMC or National Medical Council's main objective of a graduate, medical graduate, basic Indian medical graduate, the main objective how to be good clinician or good doctor based on clinical medicine. What does it mean? It means that if you ever posted in periphery where nothing is available, only your stethos is available, based on this, we can make a diagnosis. That is should be our main objective of a medical graduate. Next, please. But clinical medicine also some importance, because you see, if we are able to stand, then only we can walk, then only we can run. Clinical medicine is the basics of the any medicine. It could be medical medicine, it could be surgical, whatever field could be, because clinical medicine is the basic. But next, please. But it has some limitation also, because it is a subjective. Nowadays, many of research, even peer reviewers also want and like to have a objective value. But of course, this is a subjective. It depends upon the clinical experience, because if a experienced clinician having better clinical skill than an inexperienced or new generation clinician, because it depends upon the experience. That is the one of the limitation. And another limitation is some of cases we may miss if it's atypical or subclinical disease presentation. But dear audience, it might be observed that yes, it has been said that if you are able to diagnose a atypical case or atypical presentation or atypical disease, we may not have a 100% correct. That's why we are more important to diagnose a typical case. Atypical case diagnosis may not correct always. That's why it has been seen that atypical diagnosis rarely correct. Typical diagnosis always correct. Next, please. So coming to, that's why whenever we are taking the history, clinical examination is very much important. How to listen to the patient's version or patient's history properly, because this is also required a art of listening. Next, please. Clinical medicine, not only the patient care, it beyond the patient care, like communication, because nowadays it is very much important. Communication to the patient, communication to the patient relative, simultaneously both are important. And also ethical consideration and also legal responsibility. It is a part of clinical medicine. Because nowadays, National Medical Council frequently giving more importance to these three parts: communication, ethical consideration, and legal responsibility, because these are the main gap what we observed in the last 20 years or 30 years. And this is the main cause behind any untoward effect within the hospital premises. This is the main motto. Next, please. Coming to the next case 2, you see, this is a 45 years male, refer from a surgery department for pre-operative evaluation for fitness surgery under general anesthesia. No history of any chest symptoms, no past history of any chest disease, non-smoker, no abnormal finding in general and systemic or any respiratory system examination. It means everything normal. But it is our routine practice to do chest X-ray, and sometimes we used to do pulmonary function test or spirometry to the patient. Next, please. On chest X-ray, we found very interesting finding. You see, both right upper lobe of chest X-ray, right mid lobe, mid zone, as well as the left upper zone, mid zone, and having some sort of opacity. This shadow look like a tubercular shadow. Now question arises. Patient come for pre-treatment or pre-operative assessment to fitness for general surgery, for general anesthesia. We found this chest X-ray. Question arises, whether we should believe chest X-ray or we should re-examine the patient or needs further evaluation, or we should take another help from our senior or colleagues. Frankly speaking, all four are correct. What does it mean? Means, yes, we should believe the X-ray, because nowadays, chest X-ray, we treated chest X-ray is again in the clinical tool rather than investigation. Because nowadays, chest X-ray is available, in the handheld X-ray also available at the patient care site. Means, chest X-ray can be done at the patient's home itself. It looks like a chest X-ray. It's nowadays chest X-ray machine, handheld chest X-ray machine like a laptop. And it can be transported to the patient site also, patient home also. And the second option is also correct. Simultaneously, we need to re-examine the patient, because many often clinically missed findings can be, again, we can be reassessed by looking at chest X-ray. Yes, third option is correct. We need to re-evaluate the case. Fourth option also correct. We need to take the help of the senior. What does that mean? This patient having clinically almost normal, but investigation-wise having finding. Just we look to the just 10 years back. 10 years back, we used to give the education to our postgraduate students who are undergraduate students, also come everybody, that classical symptoms of tuberculosis is cough more than 2 weeks, fever more than 2 weeks, so and so. But a recent investigation, we found that, a recent survey and research, we found that more than 40% of tuberculosis patients are asymptomatic. Very interesting. Again, I am telling, more than 40% of tuberculosis patients are asymptomatic. What does it mean? If you will believe clinically, 100%, definitely we will miss 40% of cases. That's why we need to believe investigation also, even though patient is asymptomatic. Next. So, my lesson 2 in this case, do not forget to take help from any senior or colleague. Need to believe the era of evidence-based medicine, as I have told you. 20 years back, we used to tell that if patient is asymptomatic, don't treat the patient, even though chest X-ray is abnormal. But now, based on the recent investigation and recent evidence, we found that even though patient is asymptomatic, if chest X-ray suggestive of tuberculosis, we need to re-evaluate further. Next, please. Coming to the third case, 15 years old female brought by her parents to the casualty with complaint of breathlessness for last 2 years, 2 hours. Recently, she had appeared in the class 10 examination. No history of cough, fever, or wheeze. On vital, tachycardia, trachepnea, BP little bit higher. On examination chest, bilateral normal pressure. What should you do? Option we have, as because patient having breathlessness, should we give bronchodilator nebulization? Should we give oxygen or deriphyllin or none of the above? Basically, you see, a young female recently having given some exam, having very much anxiety, and but chest X-ray shows, but clinical findings, vitals little bit abnormal, but clinically chest is clear. What I mean to say, this patient look like some hyperventilation syndrome due to anxiety. But we should not believe blindly. I am saying many diseases, like say for example, sepsis or metabolic induced sepsis, whatever sepsis due to metabolic acidosis, patient may be respiratory rate high, patient may be chest clinically may be clear, may have some abnormality also. That means in this clinical context, we need some investigation to prove she is hyperventilation syndrome or she is anxiety induced. Means we need to exclude some disease before we start anxiety induced. Next, please. So, lesson 3 for this case, need some investigation before you stamp these known disease. Another thing is, what the mind does not know, I cannot see. That is very important in clinical field. Next, please. So, investigation-based medicine means it is driven by some of the investigation, either biochemical investigation, microbiological, or imaging, or some sort of molecular diagnostic method. Next, please. It has some importance because investigation-based medicine is the strength, like it helps diagnostic support. In addition to clinical finding or clinical medicine, because investigation will reduce the diagnosis, differential diagnosis to give the final diagnosis. It also some objective value, whereas clinical medicine have some subjective value. Whereas here investigation medicine some objective value. Many often, though patient is clinically normal, still based on some investigation, we used to give some screening tests. We used to screening test based on investigation also. And many often also nowadays, we have personalized the care based on investigation, like different biomarkers or different investigations. And also simultaneously, investigation based also help us to monitor and prognosis to define the different disease monitoring basis, also identify the disease severity and the prognosis is concerned. Next. But it has some limitation, as I have told you earlier. The first case, our dependence may reduce the clinical judgment. Means simultaneously we need to identify the false positive or false negative of this test. And also this is costly because investigation is costly as regard to clinical part also. Next. But if you will, we merge both clinical medicine and investigational medicine, clinical judgment should guide investigation, not the reverse. What I mean to say, once we clinically, both taking history and the clinical examination, narrow down the differential diagnosis, based on the differential diagnosis, we can advise the investigation so that we can stamp our diagnosis and we can proceed for the further management. Like that also, investigation should, at times also, investigation should confirm or refine our clinical suspicion. As I have told you, in my second case, based on chest X-ray, again, we can go back to the clinical examination to find something might have been missed. So, we need to some clinical correlation between both laboratory finding as well as clinical medicine. Next, please. Next, please. Please go ahead. Next PPT, please. So meeting point means both clinical medicine and laboratory medicine merged together. The next part is very important, as I am told you, that very often we should not blindly believe on the we should have a interdisciplinary collaboration between clinician, radiologist, pathologist, and researcher, because very much important to teamwork nowadays, because it helps us narrow down both clinical as well as laboratory medicine. Next, please. So, please, next, please. So, conclude my talk. The clinical medicine and investigation-based medicine are complementary. It's not competitive. It is synergetic, rather conflicting. The art of medicine lies knowing when and what to investigate and how to interpret the result in the clinical context. The best outcome arises when clinical acumen and investigation precision work hands in hand. Thank you so much for patient sharing.